Hello, and thank you all for joining today's webinar. Today, we will share 5 lessons learned for integrating HIV prevention and planning care councils. These lessons refer only to integrating planning care councils and does not refer to your integration plans. There are many ways to integrate councils, and it's sure to be a work in progress, but hopefully these 5 tips will help you ease the process. All right, and today's speakers include UCHAPS members from government and community. From Chicago, we have Peter McLeod and Patrick Stonehouse. And we also have Jackson Bowman and Jose Luis Guzman from San Francisco. I'll unmute their lines now. Hi guys, are you there?
Hi, this is Jose Luis from San Francisco. I'm with the Department of Public Health.
And Patrick and Peter from Chicago. Patrick and Peter, you may have your line muted.
Can you hear us, Ivory?
Yes, I can hear you.
Okay. So this is Patrick Stonehouse. I'm the Director of HIV Prevention for the Chicago Department of Public Health.
And Peter McLeod, I'm the Consumer Development and Advocacy Coordinator for the Ruth M. Rothstein Core Center, and I'm one of the community co-chairs for our planning body.
And Jackson Bowman.
Hi, this is Jackson Bowman. I'm in San Francisco, and I'm a community member.
Fantastic. Okay, so let's begin today's conversation, Peter, by describing the HIV landscape a few years ago when Chicago was thinking about integrating councils.
Yeah, we really began thinking about this process of how could we better integrate our planning bodies and just think more in terms of prevention and care collectively around 2006. And in 1999, we formed a care prevention work group that met regularly up until 2006. And it was really the focus of that group, and the purpose was to think about and discuss opportunities to better integrate both Ryan White program service activities as well as prevention activities. So the process had began in Chicago quite a while back. However, the impetus for really formally integrating the planning bodies in Chicago has historically had 2, a Ryan White Care Council and an HIV Prevention Planning Group that always met separately, had separate membership, separate bylaws, and separate purposes. But around 2009, a few things began happening. One was the results of HPTN 065 by Greenwich and his colleagues that really talked about test linkage to care and treatment, plus treatment. Also in 2009, HHS revised its treatment guidelines, recommending that all people living with HIV, regardless of what point in their HIV diagnosis that they were on, began treatment. So this was a significant shift in prior practices when the recommendations, whatever recommendations they were based on viral loads and CD4 counts more than just an HIV diagnosis. So those 2 things happened in 2009. And in 2010, the Affordable Care Act was signed into law as promised by the Obama administration. And also in 2010, the White House released the first national HIV/AIDS strategy for the United States. CDC funded UCHAPS in the 12 city project. So all those things were happening concurrently. In 2011, the Gardner Cascade came out. Another big thing that happened in 2011 was Dr. Cohen and HPTN 052, the international study with over 1,500 serodiscordant couples in Africa that pretty much sealed the deal in terms of this concept of antiretroviral therapy and treatment as prevention. So all those things was happening, and as they did happen, myself and other colleagues in both the community and the health department were taking back presentations about these new findings and this new research and these new policy efforts to both the prevention planning group as well as the Ryan White planning body. And that pretty much set the stage for the conversations around integration.
Okay. And Patrick, can you say a few words about service delivery at this time?
Yeah, so, at the time that, the point in time that Peter was just describing on the service delivery level, it was like the federal, state and city level policies and structural conversations were to an extent catching up with the conversations that people who were doing direct service had known for a minute, which was that the distinction between what we had typically referred to as prevention and care were largely sort of bureaucratic or administrative, but on the experience level of an individual who is living with HIV or at risk of HIV, or the experience of an individual who's providing direct services, those distinctions really didn't mean a huge amount other than which agency am I reporting to, where's my funding coming from. But as a person who was involved in a lot of HIV prevention, testing, and linkage to care, I found myself and a number of the other agencies who were doing prevention and were doing care interacting a lot more with those agencies who were on the other side of that spectrum. So if I was prevention, I was spending a lot of time working with programs that were on the care side, developing linkage agreements and establishing ways that I could provide a test and a linkage that fed into the administrative mechanism behind case management or Ryan White medical care. And so it really made a lot of sense for us, and especially as we were looking at more and more overlap of services, so looking at the linkage that was going to be required of a testing program, as well as the linkage that was going to be required of Ryan White, looking at treatment as prevention and how some of the strategies for initial linkage from prevention could be used for retention of people who are living with HIV and care. And really looking at how each of these different systems, in order for it to be received well, and in order for it to be truly supportive of the individual who is receiving the services, how we need to be seamless, it made sense, and it was really enheartening for us to see that the planning councils were thinking of, all right, how can we get our planning mechanisms to a point where they're operating as smoothly as the people on the ground level and the agencies and then the programs have been trying to figure out a way of providing the service delivery. So how can the planning be better supportive of the service delivery that we have in the ground? And so it was somewhat intimidating to try and integrate these sort of behemoth planning structures and administrative mechanisms. But from the ground level, it was really seen as being, if you all can figure out a way of doing that, that would be a beautiful thing, such that the distinction that I feel as a person who's delivering services between Ryan White and prevention, if we can remove that, or if we can make sure that the services and the needs that we're seeing on the prevention side are reflected in how Ryan White plans, if we can see how the needs and activities of Ryan White can be reflected in how prevention plans and how these can be more complementary to one another, that would be huge. And in the Chicago side, at the very least, we started to integrate housing into our planning processes as well, because we saw, again, on the service delivery side and from a client perspective, that the connections between these different sections of service delivery needed to be as seamless and complementary to one another as possible. So our planning council, the Chicago Area HIV Integrated Services Council, was an integration of prevention and housing.
Okay. So when you guys were ready to integrate your councils, how did you do that? Peter and Patrick?
Yeah, so as we began having the conversations, and we were having the conversations with both bodies simultaneously, as we were presenting these new findings and both the research stuff and the policy. changes as we presented those to both bodies. We began exploring and just kind of taking a temperature check of both bodies on how they would feel about this idea of integration. And eventually, we presented some recommendations about what it might look like, including having to request that the membership of both bodies voluntarily resign from their seats. And then if they were going to seek membership on an integrated body, that they would have to reapply for the new body. And what we did is we formed a work group that consisted of members from each body, staff from the health department, as well as other stakeholders, to begin the process of sending out a request for applications, and then to kind of like digging through the applications and reviewing the applications, and then deciding on a process or a timeline for conducting interviews. And there was a great deal of interest in this new planning body, so they had quite a few applications that they had to go through. And once they did that and began interviewing folks and came up with a set of recommendations, they brought those recommendations to both steering committees for approval. But for that, if you were a current member of either the Ryan White Planning Council or the Prevention Planning Group, and you were going to reapply, then you could not be a member of this new committee that was looking at and reviewing the applications and making decisions about who the new members were.
San Francisco, did you integrate your councils in a similar fashion?
This is Jose Luis. So we did somewhat. So we have, like Chicago, it was a long process and a lot of conversations that started, I want to say, about 7-ish years ago. And we came up with an initial plan, what we call the Integration Plan 1.0, that was from a membership of both the Prevention Planning Council and the Ryan White Planning Council, and then took that plan to both councils to move forward and integrate, and the plan did not move forward. So we went back to the leadership of both councils, went back to the drawing table and spent more time coming up with a Plan 2.0 that took about, I would say, a full year and a half of planning and meeting before the two councils voted to dissolve and integrate. As far as membership goes, we offered membership to all existing members of both councils in good standing. So those were people that were not in probation and that weren't actually in the process of leaving the council to be members of the new integrated council. And Jackson, if you could speak a little bit from the community perspective on that.
Yeah, I think one of the things that jurisdictions who are planning towards integration should keep in mind is that the way that this is being described, I think, by Chicago and by us, sounds like it's very technical, and we just had these bodies and then we made these decisions and then we move forward. But it was actually, there's like a, for us anyway in San Francisco, there was a pretty significant kind of social and emotional component of doing this that was actually the most difficult thing to navigate. I think that, part of the reason why Plan 1.0, or really the whole reason Plan 1.0 didn't move forward, was because one planning body voted unanimously to merge and the other planning body did not. And it really is an example of sort of how people felt about the work that they had been doing historically, and how they were not sure how that work would continue in this merged council. And people had a very people were very hesitant to do that. So, part of it, I think, is that the pressure to merge in some ways came from outside of the planning body, at least from the community perspective. I think for providers and people who are keyed into what was happening in research and things like that, there was a larger understanding of like, this is something that the field is moving towards. But from a community perspective, I think for people, it felt like it came a little bit from higher up or from establishment, and that it was not a grassroots project. And I think that made it a little bit difficult to move this forward. There's a lot of misconceptions about what each council did or did not do, both technically and then also sort of culturally. There was a lot of sense that the Prevention Council was in bed with the department and just was rubber stamping things, and a lot of perception that the Care Council was, disorganized and unprofessional. And we didn't really understand each other very well. And so the idea of moving forward to become one body was not something that people were that interested in doing in a lot of ways. So it took a lot of communication, it took a lot of flexibility, and it took a lot of relationship building in order to get to a place where not only could we technically pull off an integration, but that it would succeed because people were bought into that as a model. And I think that one of the things that really assisted in that was for community members to be able to understand how the care and prevention continuum are really aligned with each other. That, treatment as prevention is HIV prevention, and PrEP is part of, treatment, and it's all of these things are kind of combined with each other. And I think that people really being able to get embodied with that as a strategy was one of the things that really helped, because it helped us see the connection between what each of us was doing and how it affected the whole picture. Excuse me. And that, I think, was, I think that was really key in people feeling like this was work that they could do together.
And I would echo that from Jackson. We talk a lot about the continuum, and we speak of it as a linear thing, but we in our local body really developed this framework how everything was cyclical, and how getting folks treated and virally suppressed was actually helping those who were HIV negative not be at risk for acquiring HIV, and how PrEP was going to be changing the game and making sure people stayed negative was actually helping those that were already HIV positive by not impacting the Ryan White system of care. So we really looked at it as a cyclical system versus a linear system for the continuum.
This is Patrick from Chicago. I just want to add one thing that Peter and I observed. So at the time of integration for the planning councils here, we were both community members of, I was on the prevention, Peter was on both. And one of the things that was noticed was that there was a fair amount of people who were on, community members who were on both councils. And I think, to Jackson's point, that might have eased our process of integrating them, because it was this, and I remember the meeting where it happened, like, we're just going to see each other in 2 weeks to talk about the other side of this. Why don't we just have it all done in one meeting?
Yeah, and I think the other thing is that one difference it might have been from Chicago than what Jackson described in San Francisco is that this process was very much community driven. I mean, the health department was not in opposition and supported the process, thought it made sense, but it was not a health department driven effort. It was very much community driven. We had leadership from both bodies that supported the idea. We knew that community members had reservations. I think, in particular, from the prevention planning group, there was a belief that maybe that prevention would be kind of like second string to Ryan White, and that it might not be a priority. So we had to do a lot of work to alleviate some of those concerns and just help people understand what the paradigm shift meant and how prevention was still a priority. It just would look different in terms of our planning.
And one thing just to add, as we round this out, is that this is we're far from done with it. We are definitely still involved in a lot of efforts towards making sure that the integration is stronger, that we are equally balanced between prevention and care, or that we are able to more fully eliminate those distinctions and really just talk about the experience of people at risk of or living with HIV, rather than prevention and the care side. So, this is all our idea and what we've been moving towards, and it's been a lot of work, but we're by no stretch of the imagination done with the integration process.
Yeah, I would echo that. Even just the other day, we, in one of our work groups or committees, it was brought up that one of the training topics that people most wanted was to understand sort of prevention and the prevention cascade and what does that look like. And, we've had multiple presentations on what the prevention kind of continuum looks like. And we've gone through one cycle so far of, voting on the letter of concurrence as an integrated body. But even after all of these years of doing this, people still, I think, don't feel like they really understand exactly what the other side is doing. And I think part of that is, if someone is a consumer of prevention services, ostensibly they're not a consumer of care services, and so they don't have the lived experience of what it means to interact with the Ryan-White system of care, and the same way, for an HIV positive person. And so I think that there is going to take a lot of time to do exactly what they're talking about, which is really starting to see this whole thing as one continuum and not see it as a care side and a prevention side. And I think that that's, going to take years and years and years of practice and communication and patience and flexibility in order to achieve that.
Yeah, absolutely. Here in Chicago, it remains a work in process. I think initially we kind of perpetuated the silos that we were trying to break with our initial committee structure that included a prevention committee, a care committee, a housing committee, and then the membership committee. And it took us a whole year to realize that we were perpetuating the very silos that we had intentionally tried to break up. So, we went through that first year with that committee structure, and then going into the second year, we decided to develop a committee structure that more followed the activities described in the care continuum. So we had an early interventions committee, a linkage to care committee, access to access to ART and viral suppression committee, and then the membership committee. And I think that's when we began to encourage all the committee members to look at HIV more broadly across the continuum, and looking at the HIV services portfolio in terms of those who are most vulnerable to HIV, as well as those who were diagnosed.
And at that point, when we made that shift to the different committee structure, was when we started seeing, like, for example, people who are funded through prevention dollars to do PrEP go to the Access to ART and Viral Suppression Committee, because that's about developing structures and systems for retaining people in care to the point of achieving protective levels. Well, that's kind of what a PrEP person needs too. And similarly, started seeing Ryan-White case management programs that were looking at the primary prevention, early identification, which historically had been about testing and linkage or prevention side. And how can a case management program funded through Ryan-White try to influence how testing and linkage is done so that it's more effective coming to the role that I have at my agency?
Okay. Chicago, can you tell us a little bit more about, we've touched on it, but if you could mention the terms for your council and how you manage the challenges in maintaining a diverse council?
Yeah, sure. So membership at CAHIS, which is the Chicago Area HIV Integrated Services Council, for the most part, members have a 3-year term. And then after that 3-year period, if they're able to fulfill it, they are required to take a year off of participation in the council, with the idea that we would use that year to towards the end of their third-year term, they would be involved in trying to recruit other people who could come in and apply for membership and replace them with their perspective, their voice. And then we give them a year off to sort of rest because it's a lot of work and have some new bodies come into the conversation. We spend a fair amount of time every year as we're receiving and reviewing applications for membership, looking at how we can maintain parity and inclusion. So how do we make sure that the demographic makeup of the Planning Council reflects the demographic makeup of HIV within the city of Chicago? And then we're more or less successful in that, depending on the different elements. We always struggle with younger populations in terms of both our service efforts as well as membership in the Planning Council. We still struggle with transgender populations as well. And so it's really interesting looking at those demographics that we are most successful in bringing into the Planning Council and maintaining a parity. Are often those same populations that we tend to have greater success with in terms of service delivery. And you can make all sorts of conclusions based on if we can't retain certain populations in the services that we're delivering, why would we expect to be able to maintain certain populations in our Planning Council if we're just thinking of this as the Planning Council for it? So that's the setup that we have right now. In addition, we have some required seats from different governments and different localities like the suburbs and the county, as opposed to the city of Chicago, and representatives from the state of Illinois that are those are constant seats that are held that don't have the 3-year term limit.
Yeah, and we've always been successful in meeting the requirements, the HIV/AIDS Bureau requirement in terms of the percentage of non-aligned people living with HIV who are members of the council. We've typically exceeded that number. And then, when you count the people who are living with HIV but might be working full-time in a funded site, whether it's on the prevention side or the care side, we are typically right around 50% of membership, including people who are living with HIV/AIDS. But we were we want to be very deliberate in terms of enhancing our community engagement activities. So, when we decided on the number of voting members to the council, we added what had historically been called a set of alternative members, who we even redefined their roles and who they were. Rather than calling them alternates, we called them non-voting members. And we strongly encourage their active participation in the planning process at both the committee level as well as the full body level, but just without the rights to vote.
And so on that, what we saw in the initial years was that, we would have voting members who would be pretty active, and then alternates who would sometimes show up, and some were active and some were not. But then one of the big things that we saw was that voting members, for various reasons, fell off the Planning Council. And so wanting to make sure that we continued having the number of individuals involved as we did, we would then try to bring up alternates to become voting members. But if the alternate hadn't been involved because they were seen as being an alternate, then it was a lot more difficult to get them up to speed and get them involved in the planning process. That was part of the reasoning for changing the term from alternate to non-voting member. So you're a member. You are a member of our Planning Council. We want you here. We want you talking. Whether you have a vote or not, we want your involvement in this planning process. And then once a voting member resigns for whatever reason, which happens all the time, you're there. And if you've been participating, if you've been active, if you've been contributing, then we are more likely to say we want you to be the next voting member.
Okay. And San Francisco, what are the terms for your council? How do you maintain a diverse council?
So our term limits are 2-year, but you can have unlimited terms. So you can renew your application every 2 years. Our merged council is only about 10 months old, so we are still trying to fill some of the vacancies we had prior to the merge, as well as some areas that we feel need to be represented at the table, such as youth and our Native American community here in our 3-county area. So we are working with our membership committee to really expand and recruit in these areas. And just similarly to Chicago, just traditionally the areas that aren't represented at the table are also communities that are hard to reach for services. So this is that double-edged sword of needing them at the table to be able to inform the system of care and prevention, yet not being able to get them to be at the table and keeping them engaged in the system. So I see it as a circular system. I also would say that our membership is diverse, and we are locally struggling to keep that 1/3 of HIV positive non-aligned consumers. And some of the things we've heard from other council members, and specifically unaligned council members, is that as our population is moving out of our jurisdiction, our 3-county jurisdiction, because of our high cost of living and not increases in subsidies and services, that it's going to continue to be a struggle for us locally.
So one thing I would add from, I'm sorry, Jackson, go ahead.
Oh, no, please go ahead.
Okay, thank you. One thing I'd like to add from Chicago is the thought of, when we talk about meaningful community engagement, there are a couple of different elements to that we're really taking a look at right now. And I mean right now, like earlier this afternoon, Peter and I were talking about this. And that is, how do we ensure that the full diverse range of humans who are involved in our planning council are equally receiving and able to process and understand and buy into the things that we're discussing in our planning council? So the folks who come, how do we make sure that we're not talking, how do I make sure as a health department representative, how do I make sure that I'm not talking health department speak? How do I make sure that I'm communicating in a way that the information that we need to get across for people to be able to give a vote is reasonable, is informed, is done in a language that folks get, and in a way that they understand. And I'm not talking about vocabulary, I'm talking about such that I'm not talking around service categories or requirements from HRSA, but instead we're talking in terms of what people on the ground are experiencing. How do I make sure that we're relaying the information in a way that when a person who is an unaligned recipient of Ryan White Care Services, for example, how do I make sure we're talking that thing at me, as opposed to that's some weird bureaucratic concept. And the other thing that I think we're spending a fair amount of time on right now in terms of community engagement is how do we get out of our safe zone, which is our planning council meetings the last Wednesday of every month from 9 to noon in downtown Chicago. How do we remove ourselves from that and get into the places that those populations whom we are so desperate to hear from and to involve, get to the places where they feel safe, where they would feel more comfortable relaying their perspective and their information. And that is part of the cultural shift that we're looking to do, that we need to have our meetings, we need to plan, but we also need to make sure that we're getting out of our meetings so that we're able to receive the information, so that we can plan around getting to the people who aren't already coming to our meetings, as we discussed earlier.
Okay, so let's move on to continuous quality improvement. Chicago, what are some ways that you've been able to incorporate that in your council?
So one of the things we were talking about as we were preparing for this was this idea of that as we look at our community, as we look at ourselves as community, how do we at the same time make sure that we're valuing the voice of, for example, someone who's been in the planning process for a while and has been living with HIV for a long time and has achieved violence suppression, and is sort of like this wonderful example of what can happen if the individual and the system work well together to propel them towards the health outcome that we're looking for. How do we maintain a value on that and acknowledge that that same person maybe isn't able to speak on behalf of the 14-year-old homeless trans girl from the west side of Chicago who maybe doesn't know their status yet. But how do we make sure that we're able, that when we say community input and community planning, that community means what we need it to mean? And it's involved a lot of struggling in terms of personal identity as an advocate or as a community member, and looking at the breakdown in how HIV is transforming itself and is being transformed in our community. How do I allow for, and how do we as a council have some humility involved in that, such that, and Peter can talk about this to an extent, like Peter's been doing this for a long time. He's a tremendous advocate. And at a certain point, Peter is able to acknowledge, like, yeah, but I can't speak for everybody, and I've been doing this for a long, long time. And maybe we can get caught in knowing the language and knowing the system. And sometimes we can forget that not everybody does. So part of the continuous quality improvement that we need to be involved in is really checking ourselves and asking, are we still representative of, as a planning council, are we still representative of the people that we need to be representative of? And that includes both the 65-year-old vet, cisgender, white, heterosexual male who's been HIV positive for 20 years, and it includes that 13-year-old non-Hispanic Black trans woman who just walked in here because she heard there was something going on related to HIV services. And how do we make sure that we're able to receive and communicate effectively and plan appropriately for all of those?
Yeah, and as Patrick described, I'm a veteran at this work, and I would be the first to say that as a community member that this is an area that we need to improve on. I think that we have been deliberate in the last 6 months or so in thinking about ways that we can do that. One thing that we've traditionally done and done well is had membership, both members who are living with HIV as members who might be providers or otherwise, to participate in health department site visits to funded agencies, and to be a part of that process, and to look at quality in terms of how agencies are providing quality services. I think one other thing that we've been trying to scale up is having community forums where memberships along with health department staff go out and engage people living with HIV, people who are recipients of both the prevention and the care services, to try to gather input from them on how things are working, how what's the level of quality of services that they receive at the various agencies or institutions that they go to. But in general, I think that this is an area where we can do things differently and hopefully better going forward.
Okay, and San Francisco? Are there any other things that you might want to add about incorporating continuous quality improvement?
One thing actually I want to kind of touch on in this is leadership development and some of what the gentleman from Chicago were talking about around really kind of engaging people in the work. I think that, one of the things that has really, I think, benefited us is a model that came from CARE, which really centers the experience of unaligned consumers of Ryan White services in a way that is not tokenizing. So I think that that's one thing that I think that I came into this from the prevention side, and I think that was one thing that we did not do very well. I think we tried hard to have parity and inclusion in our membership, but I don't think that we facilitated leadership in a really authentic way. And I think for some people that leaves people feeling like their participation in this process is not that valuable, or that, and so then there's no reason to stay. And so I think that really finding ways to authentically engage community members in this work is really what helps keep the work good and helps us retain good members and helps us attract new members. And so part of the way that I think the Care Council did this that is now kind of integrated into this model that we have is that, you know, a motion might come from a committee, but before it gets to the entire planning body for a vote, it actually goes to all of the work groups. So everybody who is part of the council has an opportunity to sort of weigh in on or adjust or give their opinion on a motion. And it allows people to feel engaged in not just the topic, and it allows for people to show up at a full council meeting to vote on something that they feel that they really understand, opposed to having just be presented to them one time and saying, well, I guess everybody else is voting yes, so I'm going to vote yes too. I think that it's something that I think really has a positive impact on the sort of direction that services go in San Francisco. And I think that it allows people who are not in this work professionally, but who have come into it because they are a consumer of services, they care what services look like for them and for their community, to really feel like they have a real authentic place in shaping what those services look like.
Okay, fantastic. So Chicago, I know that the HIV/AIDS side has changed over the years, but could you mention some of the ways that you've maintained your flexibility on the council with that in mind?
How we've maintained flexibility. I think one thing was making the decision a couple of years to go from how we describe members and calling everybody either a voting member or a non-voting member as opposed to a alternate member. And what we found is that alternate members typically did not engage in the committees or the meetings until they were called to say, hey, by the way, you're now a full member. Can you start coming to the meetings? I think that was one thing.
I would add, I think one of the things that's an example of hopefully our flexibility, is that, you know, as Peter mentioned earlier, we started off with our subcommittee structure being prevention and care and housing and community and membership. And then after a while, we recognized that didn't quite make sense, and so we changed it to the structure we currently have. And as we're going through our planning process right now, the flexibility is embodied through our asking ourselves, all right, based on what we're planning, does this structure still make sense? Mm-hmm. And just being willing to ask that question, does the layout of the committee structure, primary prevention, early identification, linkage and retention to care, access to art and viral suppression, and membership and community engagement, does that structure make sense for what we are saying we want to do service-wise in the next coming years? And that's a really important question for us to ask, because it prevents us from becoming too complacent in, well, this is my committee structure. Well, if your committee structure doesn't support or doesn't complement the manner in which services are being delivered or the manner in which services are being received by folks who are receiving services, then kind of who cares what your committee structure is? It needs to be flexible in order to respond to what we're seeing in terms of the innovations of service delivery, innovations of technology, emerging needs and emerging gaps in services, and emerging populations of concern. And it needs to be flexible in order to be responsive to the experience of the people for whom we're supposed to be planning services.
Yeah, and I think that, you know, after, 7 years, I think we are now into this integrated planning process. I think we initially started out being overly flexible in terms of how we engaged non-members in our planning process. So we had a very open planning meetings where members of the community actively engaged the membership doing presentations and doing discussions and just in the course of our everyday business. I think, for me personally, over the last year and a half or so, I've begun to recognize how that is not really facilitating very productive meetings and in fact can be very disruptive at times. But we've established that culture. And now, I am talking to the steering committee members about, hey, we need to really think about how we're operating and whether or not this is the most effective way. And so I've done research and saw how other planning bodies around the country operate in this regard. And most have a very rigid process in terms of how they engage non-members during the course of their business. So it's going to be a challenge, but I am, recommending that we, just begin to operate in a way that encourages community members to come to our meetings, but having a cutoff period of time at the end of the meeting or the beginning of the meeting or whenever for community voices to be heard. But we have to get back to the business of planning and really kind of curtailing some of the outside engagement and influence in our planning activity.
Okay. San Francisco, can you give us a few examples of how you've had to be flexible in integrating your council?
I think our example of our Plan 1.0, Plan 2.0 is an example of our flexibility needing to meet council members where they're at to be able to move forward on a merging body. And I would say post-merger, really stepping back, and what we did is, and a great example is our policies and procedures manual. What we did in looking at flexibility is we took a group of members from both former councils and we had meetings about the policies and procedures, and we actually were compared side by side the procedures, and if there was similar procedures, we reconciled them into one, or maybe one council's body or one body had a better policy than the other one, so we adopted the better policy. So that really looked at our flexibility and integrating of some of the structures and day-to-day operational procedures of the council.
Okay, thank you for that. And Chicago, can you tell us about some of the program successes that you've had as a result of the integration?
Yeah, so I think a couple of the different successes that we've seen, partially it is really, you can see it in for example, the most recent comprehensive HIV prevention grant that the health department issued. It was very heavily influenced by pieces of and recommendations and ideas that went into the integrated plan that our planning council put together, and there was programmatic strategic suggestions that were made by our primary prevention and early identification committee that were turned into funding streams. There were also recommendations from our linkage and care committees that were turned into funding streams, again, funding from the HIV prevention program of the health department. And so really looking across the board, not just at the committee that has prevention on it, but looking across the board and taking these suggestions, looking at how we can integrate the service delivery models that we have in place. Similarly, we took what our Bridge Worker program, which was a prevention-funded data to care program, so focused on looking at HIV-positive individuals who have fallen out of care and using surveillance data to identify them and go and find them and retrain them in care. We created a partnership between that program and Ryan White-funded outreach and case management programs, such that we created a system of delivery that was blended between prevention-funded and Ryan White-funded. And lastly, I think one of the big successes that we've had is in looking at the data that we collect. in looking at our surveillance data and looking at our service utilization data for Ryan White and prevention, it's been a much more robust conversation as we look at from the merging of the groups. So we look at the continuum that we have here in Chicago based on our surveillance data, and then we look at our service utilization data from prevention and from care, and we allow those to really give a lot more insight into what the numbers of the cascade mean. And where our resources are going, and allows us to be in a position to more effectively plan the full wealth of resources that we have in play in a complementary manner. So I just think that it's allowed us to be more strategic. It's allowed us to be more honest with one another and with ourselves about where the resources need to be. Because we're no longer talking about, well, we need to maintain the resources for prevention. Oh, well, we need to maintain the resources for care. Like, no, we need to maintain the resources for this particular step in the cascade, because based on all of our input, this is the area in which we are having the least amount of success. And how can we best use the prevention and care dollars to bolster that particular step in the continuum?
Yeah, and I mean, we've seen gains across the continuum since integrating our planning bodies. How much I can attribute to the fact that we're thinking about HIV in a more integrated fashion, I can't say. But I mean, we've increased the number of people Chicago and the EMA has increased the number of people who are aware of the HIV status, the number of people who actually engaged and retained in care, and the number of people who are virally suppressed. Now, I imagine that all jurisdictions have seen those gains over the last 5 or 6 years, but, I would like to think that some of the decisions we've made in terms of doing things like what Patrick said, funding outreach services and prioritizing and funding early intervention services, certainly supported the ability of funded agencies to go out and find people and support them as they work their way across the care continuum from, their first appointments until they were, they felt as an individual comfortably involved in a Ryan White services program. So, I don't know how much we can attribute to integrated planning, but certainly I think that, just going through this process has helped facilitate some of those gains.
And what I would say one of the ways in which it's helped facilitate it, I think, is and this was mentioned earlier about the different cultures. There's a culture of the Care Planning Council, at least there was here, and there was a different culture of the Prevention Planning Council. And again, even if it was the same people, because there were a fair amount of people who were on both councils, but the culture and the manner of interaction were different. The questions that were being asked in the planning process were different. And I've been doing prevention for like 20 some odd years at this point, and there were questions that I'm now able to ask of prevention funded services because of the interaction with the Ryan White perspective that I might not have asked before. And I think that's happening in the opposite direction as well. That those folks who may have leaned towards prevention planning are able to ask their questions of care services, which care might not have been asking, and care may be able to ask questions of prevention services that prevention might not have been asking. And that's a really provocative, interesting, and useful way of sort of checking ourselves and holding ourselves accountable to the full wealth of perspective and resources that we have.
And I think even for some of the larger agencies, and I work at a large agency, I think that the way that they thought about their different programs, whether it was, case management and mental health services, inside of a Ryan White clinic, and HIV testing and PrEP services down on another floor, doing things to hopefully prevent new infections. I think even the way agencies began thinking about that and about looking at how even within our agency we are siloed has changed. I think even leadership at these agencies and program directors and managers have begun discussions and talking about how can we better integrate case management with early intervention services, and how can we make sure that everybody's on the same page with what our outreach workers are doing. So, you know, those are things that I just think anecdotally have changed and have supported our efforts.
Okay. San Francisco, you have the last word before we move on to Q&A.
I would say we're still in our first year. The fact that we were able to integrate and do a letter of concurrence and priority allocation was our largest success. But we're moving into our year 2 starting in June, so we're excited on what will be coming out for us.
Okay. Let's move on to Q&A. If you have a question, just feel free to type it into the chat box and we'll unmute your line. We did have one question from the New York HIV Planning Council, and they'd like to know what is the size of your bodies, like, and how large are the grants, and who are the grants from, CDC or HRSA? It's open to Chicago and San Francisco.
Sure, Chicago, we can go first. So our planning council right now is 48 members, 48 total seats. We're looking at whether or not that makes sense, because on any given meeting, we see nowhere near that many people actually showing up. So we have an allowance for 48 members, but we're talking about whether or not we need to shrink that to be more, so that it doesn't look like every meeting we're only half full. So that's part of the conversation, and that was actually an increase over what our previous body was, which was limited to 40. And then a couple of years ago, we made the decision to expand it. Now we're talking about maybe we expanded when we shouldn't have. And the grants that go into supporting it, we have CDC, Comprehensive Prevention for Health Departments, as well as CDC's PrEP Implementation and Data to Care, and Ryan White, Part A.
And for San Francisco, our council size can max out at 50. I believe we're close to 42 or 43 members. We have had some recent additions, and some folks move on to are moving out of the jurisdiction, so I'm not too sure where folks are at. And then as far as funding for the council, it comes from both our Ryan White and our CDC programs.
And if I could just add, you know, when we were planning the transition, we had wanted to do a process similar to what Chicago had, or some people suggested doing a process similar to what Chicago did, where everyone has to resign and reapply. And we would have, I think a lot of us would have thought would have wanted a smaller body than 50. But there was a lot of pushback from council members, particularly care council members, who felt like they were being pushed off and that maybe they wouldn't get their seats back. And so we ended up with the number of 50 because that was going to be the size if everybody came together and everyone kept their seats and everyone came together. And, you know, I specifically thought that that was going to be too big, but two things I think are important to keep in mind. One is we have not yet had 50. We lost a couple people like in the transition, and, you know, we've had some retention stuff going on. So, you know, we've hovered around 40 something, as Jose Luis said. So I think that not to be scared about having the size of your council be bigger than maybe it is now. And the amount of goodwill that it bought us by not having to have people resign and reapply and, you know, feel sort of like they weren't welcome and in the new body, by just allowing members in good standing to be able to, you know, people still have to fill out an application, but to basically just be able to come on and continue their service, I think is well worth the kind of larger size council.
Okay. I'm going to open the line so that Adrienne Smith can ask a question. If everyone else could mute their lines. Okay, Adrienne, go ahead.
Hello. Good afternoon.
How are you?
Great. Our question is around helping to ensure that members who want to who are not ready to disclose their status but want to be engaged in the process? How do you balance that with ensuring parity?
Well, members are not required to disclose their status. We try to track it during the process of interviewing and engaging people, just to ensure that we are meeting the federal mandates, as well as ensuring that we do have PIR, parity, inclusion, and representation. But we do not do anything in the course of our meetings that would inadvertently disclose someone's status or require them to disclose their status.
So just to add on to what Peter just said, every year when we receive our applications for membership, one of the questions on the application is, are you a person living with HIV? And if a person checks yes or checks no, we take that into consideration, but we don't share that information publicly. So when we present the slate of new members to the rest of the council, it states the number of individuals total for the entire council, including members and voting members and non-voting members who are people living with HIV, and then the number of individuals who are living with HIV and not recipients of services. But in no way, and we will not ever specify who those individuals are. We will allow those individuals to disclose on their own if they so desire, but we will not publish that information. So it resides with all of the other confidential and protected information that the health department receives.
Okay. All right. Thank you so much.
And also, and I'm sorry, this is Patrick and Peter from Chicago. We actually have to get off the line because the conference room we're using for this call is booked by someone else for starting now. But thank you very much for the opportunity and for your questions. And we will be happy to respond to any further questions and calls. Thank you very much.
Okay. I'm sorry. Thank you, Peter and Patrick. The line is open for Paul Harkin if you wanted to ask your question.
Hi there. I just wanted to make the comment, more than a question, but let the guys elaborate. In San Francisco, we recognize that you can't always have every voice at the table. So one of the great features of our groups, we have these working groups, is that you can bring in like government experts, epidemiologists, or you can bring in drug users, for instance, community members, and then they participate in those groups that work as a smaller body, and then they bring back that, the project to the whole council. And I personally, that's one of my favorite things about the council, because you can't always have everybody at the table, but this way, when it comes to key things, we can bring in the most valuable community experts. I was wondering if Jose Luis or Jackson wanted to comment on that, because I think that's a big thing for a lot of councils.
Yeah, this is Jose Luis. So that's something that's been written into our policies and procedures. That's something we haven't, again, being a newer merged council, we haven't been able to fully exercise. We're looking as work groups develop. I will say that was our strategy when we were the Prevention Planning Council alone, and that was a very useful tool to engage communities that, for one reason or another, weren't able to be members and be at every meeting, but we were able to get their inputs on specific topics such as our drug user health initiative, our mental health assessments. We've done things in the past around specifically working with the trans female community, and this was another mechanism that we used to get input from those communities without having to have those community members become members of the full council.
Okay, and we're almost out of time, but before we end, I just want to share two things with you. I'd love for you guys to complete a 2-question survey. There's a link in the chat box that links to the SurveyMonkey 2-question survey. It only takes 30 seconds, so please take a second to do that. And I also want to say thank you to our speakers, Jackson, Jose Luis, Peter, and Patrick, for sharing their experiences and their lessons learned. If you guys still have time, we have one more question from Jan from the New York HIV Planning Council. Your line is open. Okay, I will read it from the chat box. I'd like to know the dollar size of your HRSA A grant and your CDC grant, if you don't mind sharing that.
You know, this is Jose Luis from San Francisco. I do not have those numbers off the top of my head. We are split into 2 different divisions here. So our HRSA grant lives in a different division. And then our CDC grant with the step downs, we actually have a lot of support from our local government, and we've been able to backfill it. So I don't have our full number as far as what our CDC grant is in front of me.
Okay, no problem. Let's see. Okay, so that is all the time that we have today, but I do appreciate everyone joining the call. If you have any questions, feel free to email UCHAPS at info@uchaps.org, or you can always call us and chat with us. And that's it. Thank you again to our speakers, and please don't forget to fill out the survey. The link is in the chat box. Thank you guys. Have a good day.